brief, but if I'm going too fast, then please stop me, and I'll be happy to stop and discuss if there is something there that you would like to know a little bit more. So the title of the talk is it lupus, and so what I have done is that the American College of Rheumatology, one of their goal is again the same thing, is to diagnose and identify lupus at an early stage, and because of that they ask for various institutes within the US for proposals. So one of the, so I also sent them a proposal and they accepted mine. So out of those, all of the US, 7 places were identified as areas where they will be people who have been chosen by the American College of Rheumatology to provide education about lupus. So I was one of those 7 people or 7 centers. So basically some of the slides are from the American College of Rheumatology and some of them slides are mine. And again, the overall idea is to, if there is a patient in front of you, that you can identify whether they have lupus or not, and early diagnosis is shown to be very helpful and effective in terms of preventing the morbidity and mortality associated with lupus. So these are the learning objectives. So basically the thing is that we just need to recognize the signs and symptoms and when to start the workup and when to refer a patient for lupus. So why is it very challenging? Because of course, if at least in medical school you have learned about lupus, if you have seen a patient with lupus, you can probably agree with this, that it's a great masquerade, because it can present, a lot of things can present like lupus. So it's very difficult to identify. It can mimic conditions like viral syndrome, malignancy, allergic reaction, stress, and then a lot of depression, fibromyalgia, those type of things. And initially the symptoms are very vague, so they're not very specific. For example, if somebody coming with chest pain, you can identify that they are having some cardiac event, whereas patients with lupus, their symptoms are very vague. They usually say, oh, I'm just tired and I don't feel good, I have a low grade fever, and there may be some skin rash or something like that. So you just, a lot of time they get dismissed. And the other reason to dismiss them is that a lot of, again, most of the people who are diagnosed with lupus are women, and most of them are very young women. So they are usually between the childbearing ages. So a young woman coming to you and just some vague complaints like, I'm not feeling well, I just fatigue, I have achy feeling, I have fever. So a lot of time they just get dismissed. No, it's all in your head, and you don't have anything wrong with them. So that's why the American College of Rheumatology wanted people to identify if somebody is young female is coming to you and having these complaints, not to dismiss, but at the same time not to over diagnose also. So there is a balance. So you have to see when to think about lupus and when not to think about lupus. So so this slides from the ACR says that it takes about 2 or more years, but I think in Pakistan it's even longer. That I was at the meeting, then they're saying that it could be about 6-7 years or something like that before a patient, and that could mean life and death, because if you are diagnosing early, then they can have a very good outcome. Because you can imagine most of the patients are like 19, 20 years old, 21-year-old female, and if you don't diagnose them until 26, 27 and they have kidney disease, they get on dialysis. So the rest of their life is like totally ruined. But if you are able to diagnose them when there is early kidney involvement, then you can give them medication and their kidneys can be saved. So it's a big problem, and then that's why we need to make sure that we diagnose them early. So this is just what I said, that if you don't diagnose early, there is a 5-fold increase in risk of death. But if you are able to diagnose early, then you can save the life and make a big difference in the life of that young female. So again, this is the point I was just going to say, that the chances of living a full life improves if you are able to diagnose early, but if you diagnose late, then the morbidity, mortality, all of that increases significantly. So I thought that I'll just talk about a little bit of one of the cases and see if we can learn by talking about this case how when to start the treatment, when to start the workup, and how to treat patients with lupus. So typically a 25-year-old female with don't have any significant past medical history, and she complains of pain in bilateral hands and rash, which is going on for about 3 months. The pain is worse in the morning with the stiffness, swelling, and gets better with activity. and she has a rash on face which is worse with exposure to sun. So, these are the 3 points that Dr. Asad was saying, that they are very important points here in history, and that is why it is very important to get a detailed history of these patients. So, the point which is number 1 point which is very important is that you have to understand how long the symptoms are going on. So, for somebody to start workup or start thinking about lupus, the symptoms have to be present at least for 6 weeks. So, after 6 weeks then you can think about, because a lot of things like especially the viral infections can present like lupus, but they will be resolved in 3 weeks, 4 weeks or something like that. But if the symptoms are going on for more than 6 weeks, then you have to start thinking about a chronic condition, and lupus should be on one of the differential diagnosis. The second point, important point, is that the joint pain which is associated with lupus as well as rheumatoid arthritis, any of the inflammatory conditions, psoriatic arthritis, whatever. Important thing is that whenever a patient comes to you and you want to find out if the joint pain they are having or the symptoms they are having is inflammatory due to an autoimmune disease, or it is due to some kind of a joint damage or something, one of the most important thing in the history you can ask is that how do they feel when they first get up in the morning. If they feel that they are very stiff in the morning, they cannot open and close your hands, and they are not able to get out of the bed, the joints are very stiff, then that is very commonly associated with the inflammatory condition. As the day goes by, they start to feel better, and that is actually used as a criteria about how patients are doing. So, if they start to feel better after 1 hour or 2 hours, that is very typical of inflammatory type disease. But on the other hand, if patients have pain due to degenerative diseases, for example, there is joint damage, osteoarthritis or something like that, then it is the opposite. They do not feel as bad when they get up in the morning because the body has time to rest, but as they start to do activity, then they start to feel bad. But inflammatory, especially lupus, rheumatoid, it will totally opposite. So, that is a very important point in the history. The third point which is important in history is that the rash, the skin rash that happens in lupus is very photosensitive. Actually, one of the diagnostic criteria is that the rash has to be photosensitive. So, meaning that when you go outside, the UVA, UVB light exposure leads to worsening of the rash, and patients really feel bad when they go out in the sun. And one of the recommendations we always make to our patients is that to make sure that they use sunscreen when they go outside. So those are the things that you can think about in terms of when the patient comes in. So the important point is that taking a good history is very important. It can say it can help you a lot in terms of trying to understand what is the underlying disease process in that patient. So with this patient, there are some pictures that I wanted to show. So if you get that up there. So rash is not always on the face, but that's the most common presentation, that the rash which is called the butterfly rash or the mallow rash. So it's usually in the shape of butterfly, and then the nasolabial fold is always spared. So that is one of the most common presentation for lupus, and then they will tell you that as they go out in the sun. But a lot of butterfly rashes happens to other reasons. For example, rosacea is another disease where it is very typical, but a good dermatologist or if you have experience seeing patients, then you can see the difference between the two types of rash though. So she has a review system which is positive for fatigue and fever. So all of these findings are there, and when you do the examination, then this is not showing so much well, but if you try to see, there is a rash on the malar region and the nasolabial folds are safe. And then the other typical finding for patients with lupus is having a painless ulcer. A lot of time patients don't even know, but when you examine them and ask them to open their mouth, on the hard palate they will have. So this is very typical of patients with lupus, and sometimes on the nasal septum they will have also, but most of the time the ulcers are deep, so the nerve roots are also damaged, and then they don't have the pain. So the painless ulcer on the hard palate is something which is very diagnostic of patients with lupus. So the other things that you have to think about is the joint examination, and joint examination is also very important. So most of the time patients who have lupus or rheumatoid arthritis, their joint involvement is symmetrical. So for example, they have bilateral small joints of the hands that are involved. So if you look at the MCP joints as well as the PIP joints, you will see that the wrinkling or the marking of the joints are gone, and then they have fullness. The synovial lining is inflamed and it becomes full like a balloon. And then you will feel that when you examine them, then you can feel that there is a sponginess in those joints there. And then, but usually, typically, the DIP joints are not involved. So the MCP and the PIP and the wrist are the most common joints, and both with lupus and rheumatoid, it's bilateral symmetrical small joint involvement. With psoriatic arthritis, it's asymmetrical, and with psoriatic, you can also have DIP. Small joint. Psoriatic, you can have both two types of psoriatic, the axial and appendicular. So the small joints are involved, but that could be asymmetrical, and the DIPs can be involved. But with lupus and RA, only the PIP and the MCP and the wrist are involved. And of course, other joints are also involved because it's an inflammation, but just commonly what is involved. It's not like, absolute. Achha. Okay. So, and then the other thing is that you have to look at the blood test. So, you do a CBC, and as you can see that WBC count is low, hemoglobin is also low, and most importantly the platelet count is low. So, platelet is most commonly involved in patients with lupus, and they have associated immune thrombocytopenia, ITP. In the past we used to call it idiopathic, but now we call it immune thrombocytopenia, and the platelet count less than 100,000 is associated with patients with lupus. In fact, a lot of patients can only present with low platelet count. So, in a young female, if you see low platelet count, then the chances are, if they have other systemic features, that they may have lupus. They could be isolated ITP also, but even isolated ITP can evolve into full blown lupus over the next few years. And then the ESR, which is the marker for inflammation, is very high, is 60. Because it's an inflammatory disease, and also the kidneys are involved. So, the creatinine is elevated at 1.6 and the GFR is low, and then you do the urine analysis and you see that there is a proteinuria associated with it. So, the nephritic syndrome, the RBCs are there, and then and the protein is there. So, which is very typical of patients with lupus. More than 60 to 70% of patients with lupus will have kidney involvement. So, I think at this point we can say that this patient has multiple organ systems are involved. So, her skin is involved, her joints are involved, you see the mucosal linings are involved, and when you do the blood test, all the three cell lines are involved, WBCs, RBCs and platelets are involved, as well as kidneys are involved. So, at this point at least you can say that there is something going on in this patient which is inflammatory, and second thing is that it is involving multiple body systems. So, at this point we will say that she has a multi-system inflammatory disease. So, how do you go from this point to diagnosing that patient has lupus or not? So, at this point, so this is a question that what is the next test that you need to do in this patient? Any guess? Antinuclear. So, that is something that you have to do. So, you order antinuclear and it comes back a high titer. So, 1 to 640. So, the antibody titer ANA, you have to make sure that it is at least 1 to 80 or above. So, below 1 to 80 or 1 to 40 is considered negative, even though the lab will still show you as a positive ANA, but if it has to be a higher than 1 to 80, typically 160 or 320, I mean it goes double, right. So, 40, 80, 160, 320, 5, so that is how it goes. So, at this point you ask, is it lupus? Yes, no, maybe. So, I think, so is it lupus or not? So before I just talk about it, I just want to make a point here, because that is something as rheumatologists we see a lot of time, that people unnecessarily start ordering ANA. And as you can see from this, the pie that you can see there, that most of the general population don't have ANA, right. And then this slice of this pie, they have a small population have a positive ANA. And then even a smaller part of that pie is that a positive ANA is associated with a disease. So, most of the time when the ANA is ordered, it is of uncertain clinical significance. So, the reason is that the important thing is that, especially if you are in early phase of your training, is to, whenever you order a test, you need to first ask yourself a question, that what will you do with the results. So don't order a test, just like you're ordering. So whenever you're ordering, you have to have a clinical suspicion, and the test has to be ordered to prove that clinical suspicion. Because otherwise, if you just randomly start ordering test and the test comes back, then it becomes very difficult that what are you going to do with that result. So that's why I wanted to show this part. So the positive ANA is present in about 3 to 4% of general population, but it's present in almost 99 to 100% of the patients with lupus. So it's a very sensitive test for lupus, but it's not very specific.
जनरल पॉपुलेशन में उसकी रेशियो कितनी है टाइट्रेशन?
It could be anything. It could be even higher. So especially as they grow older in age, or if there's an infection or something going on, then they can have a positive ANA. But the thing is that just having a positive ANA does not mean that somebody has lupus. But on the flip side, if you're suspecting somebody having lupus, but their ANA is negative, then you have to say that it is most probably not lupus. So it's a very sensitive test, but it's not a very specific test. Yeah. So when do you have to order ANA? So you have to order if an autoimmune disease is likely, then ANA can be very helpful. So in your clinical suspicion, when you think that okay, there is something autoimmune going on, let me order ANA, then it is very helpful. But if it is not likely on your clinical suspicion, then ordering an ANA will be actually cause more problem for you. So it causes a lot of anxiety, you start doing a lot of workups, you start sending to specialists, and also it causes a lot of anxiety for the patient also, because then they say, oh, I have an abnormal blood test, but I don't know what is going on with me. So that is why it's very important that you have to wisely choose when to order it. So that is an important thing. But anyways, so the ANA you ordered, it came back positive, and like I said, the ANA is very sensitive for lupus. In fact, the new criteria that has been proposed by the American College of Rheumatology and the European Lupus Rheumatology League is that you cannot even diagnose somebody if the ANA is negative. So the first test is ANA is positive. If ANA is negative, then it may be something else. So one caveat is that the lab has to be a good lab. So you need to make sure that they are reliable, because it's a tricky test. Not everybody know how to do it. So that's why it's important that they have to understand how to do this test also. So this is what the point I was saying, that what all lupus patients have in common is positive ANA. So almost 100% of the patients will have positive ANA, and these are the antibody against anti-nuclear. So as the name suggests, it's against the nuclear antigen, and then when you do the fluorescence, it the nucleus lights up like that. So the specificity is again low, but the most important thing is that once you have a positive ANA, then you have to order more tests. And then the most important test in terms of lupus is the double-stranded DNA. So double-stranded DNA is extremely specific. So it's not very sensitive. So it's present in about 50 to 60% of the patients. But if you have a patient you're suspecting lupus and the DNA is positive, it's 100% guaranteed that that patient has lupus. So it's a highly specific but not as sensitive. And there are some other autoantibodies, and their autoantibodies can be present in lupus, but it can be present in other autoimmune diseases, and they have a specific relationship with various autoimmune diseases. So one is present, it means something else. The other one is present, means something else. But that is a totally different discussion.
हमारे पास यहाँ पे पेशेंट्स आते हैं अफोर्ड भी नहीं कर सकते, और अभी कल भी मैंने एक कंसल्टेंट की प्रेस्क्रिप्शन देखी तो उन्होंने ये सारे ही एडवाइस दिए थे, एनए भी एडवाइस दिया, एंटी डीएनए भी एडवाइस दिया, और मेरे पास है डॉक्टर साहब हम ये नहीं करवा सकते। तो अगर हमारे पास एनए नेगेटिव आ जाता है तो क्या हमें एंटी डीएनए और ये करवाने की ज़रूरत है या नहीं?
अब उसमें प्रॉब्लम ये है कि यू हैव टू मेक श्योर कि जो लैब कर रही है हाउ रिलायबल दैट लैब इज़, बिकॉज अगेन ANA जो टेक्नीशियन हु इज़ डूइंग द टेस्ट हैज़ टू बी ट्रेन्ड technician, because it's not an easy test to do. So if the person who's doing it knows how to do it, then you trust the negative ANA, then most probably there is no reason to do DNA. But if the ANA is positive, then it's important to do the double-stranded DNA, and you only have to do one time. If you do it one time, this test does not need to be repeated. If it's positive one time, that's it. Then the rest of the life it is positive. So unlike other tests like blood, CBC, other things that you have to do again and again, This is just one time in life that you have to do it. So sometimes you tell the patient that it makes a big difference, life and death difference, even though it is expensive, but if you just do one time, that will be helpful. But it has
पेशेंट ऑलरेडी 3 से 4 दफ़ा ENA करवा चुका है, वो
हाँ।
नेगेटिव है,
तो फिर छोड़ दें उसको, पीछा छोड़ दें उसको.
Sir, I want to comment that this ANA test basically is a dilutional test, and it is totally dependent upon the technician.
Yeah.
Technician is using the dilution. Totally generated.
डिपेंडेंट है कि अगर वो डाइल्यूशन नहीं सही से कर रहा है और ही डजंट नो हाउ टू रीड द फ्लोरेसेंस, देन इट्स डिफिकल्ट. So other way around it is some people are coming in with the ELISA test. The ELISA test is not operator dependent, it's a machine dependent test. The ELISA is not as good test. The gold standard is still the immune fluorescence that I showed you. The immunofluorescence, but the immunofluorescence, the problem is that it's operator dependent. The person who's doing needs to know what they are doing. The ELISA test is not as good, but at the same time, anyone who knows how to run chemistry can do it. So it's simpler, but at the same time, not the gold standard. So anyway, so you order the test and then you. So we just talked about it. So now coming back to the case that we talked about. So again I highlighted the points which are important, which are clues in your history that tells you that this could be a patient with lupus. So for example, the duration is very important. So it's been going on for 3 months. So that is when you think that this is a chronic condition. And then the joint pain, this is the typical finding of joint pain in patients with lupus and RA. So that is also an important point. And then the rash, which is photosensitive rash, right? And then her review system is positive for fatigue and fever. And then in terms of the physical examination, the most important finding here, in addition to the malar rash, is the painless ulcer on the hard palate. So those are the clues that you find. And then when you do the blood test, you see all the 3 cell lines are affected, hemoglobin is low, WBC is low, and most importantly the platelet low. The absolute lymphocyte count of 500 or below is also important, and the ESR is high, and the kidneys are involved, and then the ANA is positive. So now you are meeting all the criteria to diagnose this patient with lupus. So yes, is it lupus? Yes, it is, right? So there is no doubt at this point. So when the patient you are treating has symptoms of lupus, it's important to refer to a rheumatologist. Of course, here it's not as relevant because the number of rheumatologists are not as many. So that's why it's even more important for you to identify and recognize the patients who have lupus. There are some rheumatologists here, so you can at least send them for one time, and then they can provide you some recommendations, and then you can take over their if you're like an intern medicine doctor, then you're seeing outpatient, you can start to manage, and then once a year or something the rheumatologist can see, so you can work together with them. But the important thing is that if the patient is coming to you first, for you to identify and diagnose. The other point is that lupus is not a very common disease, so one thing I just want to make sure that not to overdiagnose also, because a lot of things look like lupus. So one thing is to not the misdiagnosis, but at the same time not to overdiagnose also. So the thing is that this is the point that I've mentioned earlier, is that if your clinical suspicion is not high, that this patient has a multisystemic inflammatory disease, if your suspicion is not high for autoimmune diseases, do not order ANA, because if you order ANA, then you get stuck with that, and then you keep ordering it ANA again and again. But the thing is that you have to be a clinician first. You have to talk to the patient, get a detailed history, do the physical exam, and then order the test to confirm what you are thinking. So this is like a summary slide about when to consider a diagnosis of lupus. It's usually seen in women of childbearing age, like I was saying earlier. There are these constitutional non-specific symptoms like fever, malaise, fatigue, which is at least has to be more than 6 weeks, and then photosensitive skin rash, mucosal involvement like stomatitis, and arthritis. The more important thing is it has to be morning stiffness, and worse, improved with activity. The ANA titer has to be at least 1 to 80 or above, and then cytopenia, kidney disease is present. So, and the other point is that even though the 90% of the patients are young female, but it can be seen in any age, and can be seen in any gender. So men also have lupus, but not as common. And then the last point is not so relevant for here, but you know, in US, black patients and patients who are Hispanic, they have much more commonly lupus than the white patients there. So this is something that the American College of Rheumatology has provided this free resource by the lupusinitiative.org. So you can go to that website. It has a lot of resources for both the clinicians, the doctors, and also have resources for patients. So you can go if you want to learn more about lupus. They have slides, they have videos, they have a lot of things, and everything is available for free. And then also, if you have a patient, you want to give them a handout. Of course, you probably need to translate it in Urdu, but at the same time, at least they have these resources available and they're freely available. So this is the website that they have. And with that, this is where I work. It's an institute that has about like 50 buildings, about 20,000 people work there, and I have one of the offices there. And with that, I just end and say if there is any questions. Thank you.
Thank you very much.